Hello everyone and welcome back to my channel. So today's topic is again a very important one. Can be asked as a long questions as well as many important MCQs also framed from here. So this is one of the most important topics in the chapter of GIT, which is the polyps, GIT polyps. And in this particular video I'm going to talk about each of these polyps in detail and all the MCQs that can be asked and all the important tables that is given here in Robbins, all of which we are going to discuss today. So without further ado, let's dive straight into this topic. Okay, so what is a polyps? Polyps is basically an elevation of the mucosa. Okay, now they are most common in the colon and rectum. They may also be found in esophagus, stomach, small intestine, and in any part of the GIT you can get polyps, but they are most common in the colon and rectum. And therefore we are going to discuss the colonic polyps basically in this topic, from which multiple questions can be asked. Now, yes, polyps can be sessile or pedunculated. If you have a stalk, then it is pedunculated. These polyps can be neoplastic or non-neoplastic. So this is the most important part that you need to remember, that this can be neoplastic and non-neoplastic. So which are the polyps which are neoplastic and which are the polyps which are non-neoplastic? Because the neoplastic polyps has got a potential to progress to cancer. So neoplastic polyp may what we mainly get is adenoma, and this has got the potential to progress to cancer. And non-neoplastic may we have inflammatory, hematomatous and hyperplastic. So I will just take you through the classification first. So you can see here that polyps are mainly of three types: non-neoplastic, neoplastic, and this is a different classification which I have just made so that I can tell you that all the important entities which are having serrations. So serrated lesions is another important short note, and which are the polyps which are serrated. Okay, so I will just take you through this very importantly. Non-neoplastic may we have inflammatory, hematomatous and hyperplastic, and in this hematomatous we have several important entities like juvenile polyposis, Peutz-Jeghers syndrome, Cowden syndrome, Cronkhite-Canada syndrome. All these things questions are framed multiple times, so we'll go through all of this in detail. Neoplastic may only one, which is adenoma, and this adenoma can be of several types. It may be tubular, tubulovillous or villous type. In adenoma, we are going to find two important topics, that is FAP and HNPCC. Now coming to this part which is serrated. So serrated may have certain non-neoplastic lesion which is serrated, or else neoplastic lesions which are serrated. So hyperplastic polyp is coming under the serrated classification, and this is non-neoplastic. On the other hand, sessile serrated adenoma and traditional serrated adenoma, these two are another two serrated lesions which are neoplastic. Okay, because they are adenoma, right? So this is not a classification. I've just mentioned the important entities over here, right? So whenever you see this word adenoma, this means it is neoplastic, and this can again convert it into carcinoma, because when I will take you through the molecular pathogenesis of colonic carcinoma, you will see that over there is one mechanism which is the adenoma carcinoma sequence, right? And that is why adenoma is neoplastic and it has got a high risk of getting progressed into carcinoma. So now once this basis is clear, we'll go into each of these in details. So a hyperplastic polyps is typically found in the left colon, typically less than 5 millimeter. They are smooth nodular protrusions of the mucosa, mainly found in the colon and rectum. They are composed of mature goblet and absorptive cells with a serrated surface architecture. I have mentioned that hyperplastic polyp is coming under serrated lesion. So because they have a serrated architecture, that is a morphologic hallmark of these lesions. So now you know how important it is to know which are the lesions which have serrations, because agar serrated architecture hai, then that is the morphologic hallmark of these lesions. But the serrations is typically restricted to the upper third of the crypt. So if the serration is restricted to the upper third of the crypt, then it is a hyperplastic polyp. But if the serrations are present throughout the lumen, they form a L-shaped lumen. Basically, the serrations are present all throughout, then that is basically a sessile serrated polyp or sessile serrated adenoma, and this entity is having dysplasia. So if I just take you through this and make you understand here that this is having the serrations only in the upper third, right? and this is something which is sessile serrated adenoma or polyp, whatever you mention. This is the one which has the serrations throughout. Okay, this is having serration throughout and they form this L shaped lumen. And because this is an adenoma, means this is a neoplastic. I've already mentioned here, because this is neoplastic, the additional feature which we'll get here is dysplasia, because you know that dysplasia is plus plus here, but here this dysplasia will be, there is no dysplasia negative in hyperplastic polyp. So if I just show you this image, you can see that this is the polyp surface with irregular tufting of epithelial cells, and there is so much of epithelial overcrowding, and you can see that these are the goblet cells which you can see, and this is the serrated architecture. So now you can see that this lumen, so what is happening, this portion there is epithelial overgrowth, this portion, and this portion also epithelial overgrowth. This lumen was supposed to be circular, no, like this, but in some places you can see that there is epithelial proliferation like this, and therefore this is basically forming a kind of an serrated lumen. Okay, so that is what is mentioned over here, that epithelial crowding produces a serrated architecture when crypts are cut in cross section. So these crypts are cut in cross section, and because of this epithelial proliferation you can see that this is assuming a kind of an serrated architecture. Okay, so, colonic hyperplastic polyps are benign epithelial proliferations that are typically discovered in the 6th and 7th decade of life. It is because of a decreased epithelial cell turnover and delayed shedding of the epithelial cells. So, there is delayed shedding and a decreased epithelial cell turnover, because of which there is piling up of these goblet cells and absorptive cells, and these lesions are without malignant potential. The chief significance is that they must be distinguished from sessile serrated adenomas, which are histologically similar but they have a malignant potential. So two entities which have to be differentiated from each other is, number one, hyperplastic polyps should be differentiated from number two, sessile serrated adenoma, because this has got malignant potential but hyperplastic polyps are benign. So if I can just take you through this once more, that sessile serrated adenoma is neoplastic. It is predominant in the right colon. The serrations are present in the entire thickness throughout the lumen, and what they form is basically an L-shaped lumen. Okay, and if you talk about the hyperplastic polyp, then it is non-neoplastic, present in the left colon, and serrations are limited only to the upper layer or the upper third, rather basically it is the upper third. Okay, so this is the basic difference. Now we'll talk about the other entities. Inflammatory polyp में ज़्यादा कुछ याद रखने का है नहीं. It is basically a part of the solitary rectal ulcer syndrome. Clinical triad of rectal bleeding, mucosal discharge, and inflammatory lesion of the anterior rectal wall. The underlying cause is impaired relaxation of the anorectal sphincter that creates a sharp angle at the anterior rectal shelf, and the distinctive histologic features include mixed inflammatory infiltrates, erosion, and epithelial hyperplasia, together with the prolapse-induced laminar propria. So you can see this is basically a solitary rectal ulcer. Now, inflammation, why there is so much of granulation tissue, as you can see. See, this is basically the granulation tissue, how it looks under the microscope. You can see this tissue capillary proliferation within the laminar propria, which is caused by repeated erosion. These are basically the dilated glands, proliferative epithelium, and superficial erosions, inflammatory infiltrates, all of which you can see in the inflammatory polyp. Now coming to this hematomatous polyp, a subset of these polyps can be considered to be premalignant, neoplastic, and much like adenoma. So we have to know what are its extra intestinal manifestations and what is the possibility that the family members also affected, because these are also sometimes premalignant. So in this we are going to learn some very important entities. Number one is juvenile polyps, okay, and Peutz-Jeghers syndrome. So these two we are going to learn over here, and I just want to show you this table, and I just cannot stress any more on the importance of this table. This is such an important table, and it's a last minute revision topic for your exam. And you know that this series, which is the Neet PG Concept Cup, in this I basically only take up those which are the previous year's questions or last minute revision topics जो है मैं सिर्फ उसी को discuss करती हूँ. So this is one of it, and this chart is super important. Along with that, this one more chart, which is again another very important chart. Questions can be framed anyhow from this, and there are very few important differences. Like you can see, I'll just show you one point here, that see, this is autosomal recessive. Okay, दिस इज ऑटोसोमल रिसेसिव एंड द अदर टू आर डोमिनेंट. सो ये ऐसा क्यों है या फिर व्हाट इज दिस, आई कम टू इट लेटर ऑन, बट आई जस्ट वांट टू शो यू द इंपॉर्टेंस ऑफ दिस चार्ट्स. छोटे छोटे पॉइंट्स हैं ऐसे जिसको हम मिस कर जाते हैं और बाद में हमको कॉन्सेप्ट में वी हैव लैक्यूने बिकॉज ऑफ दैट. सो एनीवे, लेट्स कम बैक टू दिस. एंड talking about the juvenile polyps, we can see that this is basically malformations of the epithelium in the lamina propria. Now, children younger than 5 years of age, they have this kind of polyps. This is basically located in the rectum and they cause rectal bleeding. In some cases, intersusception, intestinal obstruction, polyp prolapse may happen. If these polyps are sporadic, then it's fine. That means they are usually solitary, means you have only one polyp in cases of sporadic conditions. But in cases where there is a juvenile polyposis syndrome, that is autosomal dominant, and there you have 3 to hundreds of hematomatous polyps. So if you come to this chart, see the first one is juvenile polyposis. Juvenile polyposis means here you're going to have 3 to 100 kind of polyps. This is autosomal dominant. I am not talking about the sporadic ones, but this is basically the polyposis syndrome, which is the autosomal dominant type. So what are the GI lesions you have? Juvenile polyps, increased risk of gastric, small intestinal, colonic and pancreatic adenocarcinoma. You have congenital malformation as a part of the extra intestinal manifestations, and the mutated genes are very important for your MCQ. So all of this is important. Every point in this chart is important. You can't afford to miss any of this point, and the ones I've highlighted is the utmost important points. So the mutated genes here in this is the SMAT4, the BMPR1A and TGF beta. So SMAT4, BMPR1A and TGF beta, all these three are important in this juvenile polyposis. It is basically less than 3 centimeter in diameter. The seeds are dilated with mucin and inflammatory debris, right? Now, yes, mucosal hyperplasia is the initiating event. The most common mutation is the SMAT4, which encodes a signaling intermediate in the TGF beta pathway. If you talk about the SMAT4, I'm just going to write it down over here. SMAT4. This is connected to the TGF beta pathway. And you know that if this is present, then the children or these patients will have juvenile polyposis syndrome, and they also have hereditary hemorrhagic telangiectasia. ठीक है, so juvenile polyposis भी present है, and in this patients HHT is also present, and that is why if you get this gene, it is basically associated with this. And of course this is always present, yes. Now in the other conditions, you have this BMPR1A, which is a kinase as a member of the TGF beta superfamily. So this is also connected to TGF beta, but then you don't get this HHT in this BMPR1A pathway. Okay. Now if you talk about the Peutz-Jeghers syndrome, a very important topic, this is an autosomal dominant one, and this has multiple GI hematomatous polyps and mucocutaneous hyperpigmentation. This is a very important point. There is dark blue to brown macules on the lips, nostrils, buccal mucosa, palmar surfaces, etc. Now, Peutz-Jeghers polyps can initiate intersusception, which is occasionally fatal. You have mucocutaneous hyperpigmentation. You have autosomal dominant inheritance. You have a risk of other malignancies, and the gene which is involved is STK11. Very important exam question. The gene involved is STK11. It's a tumor suppressor gene that regulates the AMP activated protein kinases, or the AMPK, which controls cell polarization and acts as a brake on the growth and anabolic metabolism. So here, if I just come back to this diagram now, so which are the important points we must highlight? Number one, there is STK11 or LKB1 gene mutated. Most important is STK11. There is mucocutaneous hyperpigmentation. There is perioral melanosis. Obviously, it is because of this mucocutaneous hyperpigmentation only. You have this Christmas tree appearance. So Christmas tree appearance is basically the histological feature. I'm going to come to it. Now, in the GI lesions, you have the arborizing polyps. The small intestine has the polyps, which is more than the colon. Now, a very important point, because mainly the polyps are present in the colon. This entire chapter that we are reading, all these polyps are mainly present in the colon or the rectum. But here in this particular case, we have arborizing polyps, but these polyps are more predominant in the small intestine rather than the colon, as you can see here. Okay, so this is an important point. Don't get confused. Yes, you do have pigmented macules, and there is an increased risk of several other cancers like colon, breast, lung, pancreas, thyroid, etc. Okay. So this point I already mentioned that this is most common in the small intestine. Now, a characteristic arborizing network of connective tissue, smooth muscle, lamina propria, and glands lined by normal appearing intestinal epithelium. So if you just see this image, there is a overlying stroma which is composed of smooth muscle bundles cutting through the lamina propria. So this is basically the smooth muscles. You can see how this is basically cutting through the entire lamina propria. This area is lamina propria, and these are the muscle bundles, the smooth muscle bundles which are literally cutting through the lamina propria, and this is why it is called as arborizing pattern and the Christmas tree pattern. Okay. So I will just write it down over here. This is basically the arborizing pattern and the Christmas tree appearance. Okay. Now this is also very important point that this is having a complex glandular architecture and the presence of smooth muscles, and these features distinguish this Pius Jaeger polyps from the juvenile polyps. So juvenile polyps may you don't have this kind of complex structure and the smooth muscles. Okay. So the arborization and presence of smooth muscles intermixed with lamina propria are helpful in distinguishing these polyps from the other polyps of juvenile polyps. However, the absence of STK does not exclude the diagnosis. It is not that in all the patients you are going to have STK level mutation, but this is mainly found in this condition. Now coming to this important topic, which is the neoplastic polyp. Very important, these polyps are colonic adenomas which are precursors to majority of colorectal adenocarcinoma. I have just mentioned this point earlier. Now, adenomas are epithelial neoplasms that range from small, often pedunculated polyps to large sessile polyps. Okay, so this is very important because it has got a risk of getting progressed to carcinoma, and therefore the individuals who are at increased risk, including those who have this positive family history of colonic adenocarcinoma, they should be screened at least 10 years before the youngest age at which the relative was diagnosed, because colonoscopy is basically a preferred approach even for screening. Now let's come to this very important point, that is colorectal adenomas are characterized by the presence of epithelial dysplasia. So in any kind of a neoplasm you do have epithelial dysplasia, and the hallmarks of epithelial dysplasia are nuclear hyperchromasia, elongation and stratification. So these points basically direct towards epithelial dysplasia, and these points are not there in case of benign polyps. Okay. Another important point here to mention is that the villus adenomas, they harbor cancers more frequently than the tubular adenomas. Okay, but this also correlate with the size of the villus adenoma. So as I mentioned earlier, that you have something which is tubular adenoma, tubular villus adenoma and villus adenoma. This villus adenoma is basically kind of associated with more cancer later on. Sessile serrated lesions, also referred to as sessile serrated adenoma, they overlap histologically with hyperplastic polyps but are most commonly found in the right colon. Okay, this is a very important point. I've already mentioned this point earlier. Despite their malignant potential, these polyps lack typical cytologic features of dysplasia. Okay, they do have malignant potential, but they do not have cytological features of dysplasia. Size is the most important characteristic that correlates with risk of malignancy. Very, very important. Size rather than the type, which correlates with the risk of malignancy. So here you can see this is the tubular adenoma, this is the villus adenoma, this is long slender projections, and this is the sessile serrated adenoma, which is having goblet cells, and they do not have a cytological features of dysplasia. So the point that I mentioned over here, don't write this in the MCQs. Don't write this in the MCQ. This is basically for explanation but not for your MCQ. MCQ में you have to write that dysplasia is not present. Okay, sometimes the practical चीजें जो है वो MCQ से differ करता है, and this is one of the example. MCQ के लिए we'll write that cytological features of dysplasia is not present. Now, a FAP is an autosomal dominant disorder in which the patients develop numerous colorectal adenoma as teenagers. It is caused by somatic mutations of the APC gene, which is a key negative regulator of the WND signaling pathway. At least 100 polyps are necessary for diagnosis of this classic FAP. This is familial adenomatous polyposis. 100 polyps are required, very important point. Now, colorectal adenocarcinoma develops in 100% of untreated FAP patients before the age of 30 and before the age of 50 nearly. So if these FAP patients are not undergoing a prophylactic colectomy, then these patients will develop 100% of them will develop colorectal adenocarcinoma. So this is highly important. Okay, so as a result, the prophylactic colectomy has to be done. Okay, because this colectomy will prevent the colorectal cancer. The ampulla, vater, and the stomach are most common extracolonic sites of adenoma in the FAP patients. So, which are the two important sites? Ampulla, vater, and the stomach. Okay. Now, a FAP is associated with a variety of extraintestinal manifestations, include congenital hypertrophy of the retinal pigment epithelium. This is a very important point, that FAP is associated with congenital hypertrophy of the retinal pigment epithelium. A very important MCQ, because we have seen that APC mutation is the one which is happening over here, and there are specific APC mutations which may be also associated with other manifestations of FAP, and it also explains some of the variants like Gardner syndrome and Turcot syndrome. So if I just come to this and talk to you about this, familial adenomatous polyposis, we have just learned it is because of the defect in the APC and the WNT signaling pathway. The target gene is the APC and it is autosomal dominant. Very important. You do have all this kind of adenoma, but then it is also having a high risk of progression to adenocarcinoma. Now you must understand that some polyposis patients, they do not have APC mutation. They do not have APC mutation. So these patients, what do they have? They have a biallelic mutation of the base excision repair gene, which is the MUTYH, also known as the MYH gene. Very important. We always remember this entity, which is the FAP, and we know that the APC gene is getting mutated over there, but we don't remember this particular aspect, which is very important to know and remember, because MCQ may you will get somewhere or the other this option will be there, because this is very much connected to FAP. APC is getting mutated in the FAP, but here APC is not disturbed. Here the APC is there, fine, normal, but there is mutation in a specific gene, which is the base excision repair gene known as the MUTYH. And very important point, this is not autosomal dominant, this is autosomal recessive, and the term we use here is MUTYH associated polyposis or MAP. So MAP hai FAP ka bhaiya, and there are very striking differences of MAP with the FAP. Number one, I mentioned the gene that is present here mutated is completely different. It is the MUTYH gene mutated here, and that's why this is named as MAP. And here the number of polyps present is less than 100. As I mentioned earlier that in FAP the number of polyps has to be 100, minimum 100, लेकिन यहाँ पर जो polyps है that is fewer than 100, and it appear at later ages, they appear much later. Colon cancer development is also delayed, so even this is not that dangerous as FAP, but it is also dangerous. Okay, so now if I come back to this, I hope that now this is very much clear to you that we have this special entity which is the MAP. It is because of the DNA mismatch repair. The target gene is MYH and it is autosomal recessive. Now, the other most important point which we want to learn is the hereditary non-polyposis colorectal carcinoma, or HNPCC. Now, this is basically because of the mutations in the mismatch repair gene that encode protein responsible for detection, excision, and repair of errors that occur during DNA replication. This is also known as the Lynch syndrome. This also has a risk of cancers at several other sites like colorectum, endometrium, stomach, ovary, uterus, brain, and all of this. Cancer in these patients tend to occur at younger ages and often located in the right side of the colon. The genes involved here are super important. It is MLH1 and MSH2. So you can see here that it is because of DNA mismatch repair. MSH2 and MLH1 affected, its autosomal dominant and right side. Very important. Okay. So now just going and brushing up through this particular chart, which is extremely important. We are done with this, and now Peutz-Jeghers syndrome also we are done with this. Now Cowden syndrome and Bunyan-Ruvalcaba-Riley syndrome. We have this PE10 mutation, PI3 AKT pathway is defective, and we have this hematomatous polyps, and very important, we have some benign skin tumors, but the malignant thyroid tumor is present as a part of extra intestinal manifestations. So it's a very important question There is a no increase in GI cancer. There is no increase in GI cancer, a very important point. In all the other cases, you can see that along with the other cancer, the GI cancer's risk is also increasing, but here there is no risk of increasing in the GI cancer. And we also have this tricholemoma present in this particular entity. Now, Cronkhite Canada syndrome, this is also hematomatous polyps are present. We have nail atrophy, hair loss, abnormal skin pigmentation, etc. Tuberous sclerosis, may we have these genes mutated, and we have intellectual disability, epilepsy, etc. Now, FAP may we have all these important points: classic FAP, attenuated FAP, Gardner syndrome, Charcot syndrome, and this one which I've already discussed, which is the MAP version. Okay, so now please remember that Gardner syndrome, we have the osteoma, desmoid tumors. Okay, and in the Charcot syndrome we have the medulloblastoma and glioblastoma, and in this particular MAP syndrome we have the risk of polyps, which I've already mentioned. And a very important point which I'm trying to highlight is that you can see that in the FAP, in all the conditions, you have this APC gene mutated, but only in the MAP you have this MUTYH gene mutated. And not to forget, this is autosomal recessive. Okay, so this is basically the entire of the chapter. I hope that I have been able to tell you and take you through the most important points which are high yielding for the MCQ exams. So if you like my content, then please support me by subscribing to my channel. If you have any personal query, you can mention down in the comment section below. I would really appreciate your feedbacks. I will meet you very soon in the next episode. Till then, take care, keep studying, and thank you for watching.